we often have talked about trying to make the business case for total worker health and the quality of work life. And so I want to raise some questions. Should we make a business case? How can we, or how should we make a business case? And at what time and what point? Because at various times there's more opening than ever. But I really wanted to start with, what does a business case mean in an era of, I'm going to talk about three different things. The first one is this concept of Fischer work, which a number of you are probably familiar with. This is introduced into the occupational health literature by David Weil, who wrote a terrific book called The Fischer Workplace: Why Work Became So Bad for So Many and What Can Be Done to Improve It. But the core concept of Fischer's work is that much of the modern workplace has been farmed out, in the sense that companies that had, particularly legacy companies, that had been traditionally horizontally integrated, have farmed out many of their functions, anywhere from maintenance to subcontracting, and without really clear legal responsibilities or fiduciary responsibilities for the workforce, and that this is a very large-scale phenomenon, which makes an integrated approach difficult. I also wanted to raise the question about fractious workers, and what I meant by that is, what is the health of our workforce right now and the health of our population? Casey talked about opiate use, but I think we need to delve a little bit more, because there's some profound phenomena going on in the American public right now and in our workforce. And finally, I wanted to talk a bit about what I'll call fractious business. The idea that we have enormous changes going on in the structure of corporations and firms that I think are just becoming realized, although there was some prediction even back in the 1980s that this would be happening, where companies are becoming more centralized in many respects. The company label or brand becomes more important as its functions become, and its diversification becomes more limited. So all of these are important because they reflect that when we try to make what might be a business case, we're dealing with a very changing reality. So I know I shouldn't offer business, busy slides like this, but this is a little bit of a thought exercise, because as some of you know, there's been a strong counter argument about making health promotion and health and well-being introductions with the idea that the interventions simply don't pay for themselves. The return on investment is not positive. The benefit cost ratio is not convincing. And here I use abbreviations. EDU is a cost equivalent. And I talk about things like quality of work life, increased OPC is increased effort at the individual level in the workplace, and workforce participation. And at this point, these are really seen as negative values. And the reason that I wanted to run this is that if we take as a bit of a thought experiment, a very successful intervention program where we have terrific benefits, absenteeism is way down, hospitalization costs are way down, the programmatics are expensive, and the staffing for them are expensive, but they're considerably offset by these benefits. But if we start talking about negative values in terms of some of these additional elements that I mentioned, which would alter and change the organizational nature of interventions, it almost never makes sense to have really health and well-being integrated, even total worker health type interventions. No matter what the ethical side, the traditional business case, which is that there is no added value from extrinsic or intrinsic improvements in work life, which often seems to be the case. Increased productivity, lower direct costs, these are often not clearly measured and indirect. And in fact, another busy slide, and this is the last time I'm going to do this, but it's just a combination of some work that was done on workplace health promotion and return on investment some years ago, that some of the attributions of significant gains from intervention are based on productivity or so-called improvements in presenteeism profiles. But in fact, the reason they look positive is because the interventions are widespread. They're inexpensive per person because they're largely cognitive sub-behavioral. And we're measuring survey-directed outcomes, which may not really show up as a so-called bottom line if we simply use the top line, bottom line input-output thinking. And one thing to even think about with all of this is why we might look at some of these so-called negative values or added values as externalities in terms of the workplace. For example, you don't look at raw materials, you don't look at essential safety and protection as externalities, you look at them as facility costs. But that's not how we look at interventions and some of the human effort that may be involved. And because of that, it's been very hard to make this case. And as a lot of you know, many companies have already made the decision, and there's quite a significant literature about how programs and interventions directed at workforce well-being just don't pay for themselves. So let's take that as true, given the current economy. So I want to talk a little bit now about how work is changing and what I'm calling Fischer work. And for those of you who don't follow this, I think there's a few points which are really worth making. Something began to happen in the United States in the late 1970s and early 1980s, where the labor share of national income began to drop precipitously. Now, this is total GDP, and what we can see is that over a 40-year period, and this is just pre-COVID, we see kind of a new equilibrium, but over this period, what we've seen is approximately a 25% decrease in the labor share of national income. And by labor share, we mean wages, we mean benefits, some intangibles, but primarily measurable outcomes that go to labor in contrast to what stays with the company itself. And this is a dramatic approach. What we've really seen is about a 25% drop in the labor share of our national income over the past 30 to 40 years. And this is a similar demonstration, but it really represents something more narrow. If we take out self-employment, if we take out farming and agriculture, and we're left with business employment, business income, the deflection is a bit later, but we have a dramatic change in inflection in around 2000. And what we see is the same endpoint, that as we get towards the current times, we have roughly a quarter of national income, or business income, that had previously gone to labor share, no longer going to labor share, but going to companies of capital, or even for that matter, facility costs. So something profoundly has changed here in the last 30 to 40 years in the United States. And when we look at it in aggregate, it's a really dramatic change. And of course, two questions come about, where is national and business income going? And how are we going to justify increased investment in people if in fact the labor share is in a period of precipitous decline? Now, what I wanted to do with this slide was really just emphasize the same point. And there's really 2 points in looking at productivity growth. One of them is that, as a lot of you know, productivity growth has been relatively consistent, not flat, but relatively consistent over the last 40 years, over the same period. We have increases and decreases. When we have recessions, we have a decrease. But there's really 2 messages with all of this. If our output per working person is roughly the same and is positive, and our overall GDP is growing, where is this going? It's clearly not going to labor share. And I'm also going to raise an issue in terms of the current workplace. It's not universal. If we really were seeing these enormous changes in technology, which was affecting output, we would expect that productivity growth would be soaring, but that's not been the case. So in fact, we have relative constancy, and we could talk about international markets and competition, and that's a much longer talk. But in the gross and the aggregate, we're really not explaining this very well. The workforce is not being automated out, and the workforce is not sharing in what's been a significant gain in productivity and income. Now, what is going on in the workplace or in this Fischer workplace? One of the things that's going on, and this goes back to David Weil's very important book and concept, which if you're not familiar with it, it's one of the rare terms that's kind of entered common use in occupational medicine, but quite valuably. What we're seeing is that we're seeing more and more contracting out. And this is from a David Weil lecture. And whether it's independent contracting, contract firms, on-call workers, temporary health agencies, going back to the mid-90s, we've had a consistent increase in the share of workers in each section who are involved in alternate work arrangements, just to say that they're not working for the traditional firm or legacy company. And one of the issues that David Weil writes about very consistently is that workplace regulation, and a lot of you know this, for example, wage and hour controls, health and safety controls, have a much more nebulous attachment. Although there's been some movement in the courts, it's still been pretty blocked. A much more negative attachment of the worker to the hirer, because the immediate employer is not in fact the legacy company. Now, this actually does have an interesting side to it, because the legacy company, as we evolve, has some different meanings. Brand name, evolving consciousness about equity, fairness, environmental responsibility, social responsibility are starting to really enter our broad category of terms. And if they had very little weight until perhaps the last 5 years, it seems in many ways that COVID-19 has accelerated the appreciation of these things on a much broader scale. But the problem and the situation, I won't call it a problem, the situation is formidable. What we have is that work is increasingly being farmed out from our traditional corporations. Fischer, if you like. Now, this was from Katz and Kruger, who looked in the International Labor Review at these issues over 20 years between 1995 and 2015 on the growth of alternative work. And what you can see is that in a variety of sectors, well-known construction, but also in manufacturing, in public administration, in business services, with the exception of finance, interestingly enough, which seems to be protecting itself. Most of our sectors have in fact involved larger percentages of contracted work. In fact, Katz and Kruger have estimated that almost somewhere between 80 and 100% of our net employment gains over the last 25 years have really been in this contracted Fishered sector. So at the time that we're talking about company responsibilities and trying to get companies to adopt programs around total worker health and well-being, we see a very different phenomenon going on, which is that our workforce has been growing, not intrinsically in terms of the host or legacy company, but in terms of expansion into sectors from contracting companies. Now I want to talk a little bit about the next topic, which I'm going to call fractured workers. So some of you have seen this from the NRC reports on comparisons of US health with industrial peer countries. And of course, this is very broadest view. It's at a very high level because we're talking about the entire population. This is years of life lost before age 50 in men among 17 peer countries, most of them European, but also Japan. And if you haven't read the National Research Council report on shorter lives, I would really urge you to do it. It's a bit out of date. It was published 9 years ago, but the numbers are still quite relevant. But what we can see is that in every single category of disease, where we're having impacts on specific causes of death among men, the US is well above the international averages of its peers. And that's a doubling in younger men of all-cause mortality, but also in in injury, in drug-related causes, as we know, in nutritional problems and communicable diseases. In every area, we're doing worse. And so the obvious question comes up is, well, has this always been true? Well, some of you with a historical note will know that the US for before World War II was noted as the champion of public health. And in fact, if we look at the NRC reports, and again, for those of you who are familiar with this, it's redundant, but this is male life expectancy at birth in the US compared to 21 other high-income countries. So if you go back to 1980, and these trends continue. In fact, we've had a real drop in life expectancy in actual terms, not relative terms, with COVID-19. What we end up seeing is that although there's been an increase in actual longevity in men, we've gone from a place where we were right around the middle compared to our economic peers to being dead last in terms of male life expectancy. And that's over this 40-year period, which I'm not going to draw causality or even association, but it is coincidence. This is a period when we've had a very declining role of benefit within our workforce. Now you could say, well, it's just men. You know, men don't take care of themselves. They don't go to the doctor. They smoke too much, but they used to anyways. Except the same thing is true for women. So we went from a period 40 years ago where women were doing pretty well in the US. They were around the high middle. And not only have they dropped to dead last compared to peers, but unlike men where there's been some slight increase in longevity, in women there really hasn't been much of an increase in longevity. So this is life expectancy. It's the crudest of all figures. On an earlier slide, we were talking about deaths and lost years of life in a younger group. But what we see is in something like a 40-year period, the United States has been the laggard, has been the real outlier in the industrial world. So I wanted to talk here about, this slide is total worker health or total worker health. And what do we really mean? Who is the total worker health for? Now, this is a kind of an editing or a recalculation of numbers which have been published around LiveWell, which is a very well-known Johnson & Johnson program going back to the early 2000s, or the first decade. And this was a period where we had a significant 9% growth rate per year in per annum productivity in Johnson & Johnson, and a very large increase in so-called shareholder return. And this is comparing with the normative comparison being a ratio of 1, a variety of different health behaviors. So if we look at some things like blood pressure, there were some positive changes. If we look at cholesterol, they were and stayed around their peers. Tobacco use, there was clearly decline compared to peers. Physical activity was fairly constant. So we had some improvements, blood pressure, a bit in obesity, a bit in significant in tobacco use. But if we look at depression and stress, you know, the mental health issues, which Casey talked about, they've gone through the roof. So this is a very lauded health improvement, health intervention program that got many national awards and recognition. But I would like to emphasize why I have total worker health italicized here, because it is total worker health for whom? And if in fact we have sort of traditional health benefits from health promotion from active interventions, there also seems to be a compensatory side, which is far from beneficial. And this again deals with some of the questions about life quality and mental health, which are so important. Now I'm going to talk a little bit about some of our own work. I feel more comfortable talking about the things we've done. So some of you know we've had a 15-year study funded by NIOSH of the aging workforce. We started with 6 manufacturing companies in Connecticut, mid-sized manufacturing companies. We chose them because we'd had long-standing relationships. They were very stable companies. we were expecting that we would have a period of at least 5 or 6 years when nothing was particularly going to happen in the outside world. Of course, a year later, we had the Great Recession, and 12 years later, we had COVID-19. But I really wanted to point to a couple of things here, because I think it tells us something about the views and the status of a workforce, even in what had been considered to be a fairly stable sector, where there were retirement plans, although I have to say the retirement plans are quite diverse and really all over the place, from defined benefit to defined contributions to various kinds of hybrid forms in between. And what we had seen, I think there's two things I want to point out here. One was we were looking at workers who were employed or retired. And what we saw is that particularly among workers who were employed, workability, which a lot of you know is a combined measure looking at physical health, psychological health, quality of work, physical demand, organizational culture at work, had been a steady decline. The 1, 2, 3 stands for time periods, but this is 2008 to 2022. And what we see is that people, particularly those who remain working, report a significant drop throughout their work lives in this period. And with the one change being some improvement, actually, as people are planning to retire. This is from the JCQ, which a lot of you are familiar with. It's supervisor support. I'm pointing, I could have taken 20 other measures, but we chose this one because I wanted to point out something that's very significant. First of all, we see the same type of pattern, even though allegedly we're measuring something entirely different. And so if we took from this that the real problem is bad supervisors, that would be an error. So I think there really are two things we learn from this. One is that although we give a lot of credit to our measures and our psychosocial measures of satisfaction with work and organization of the workplace and psychosocial factors, we see that they actually move in a kind of tandem, which suggests that they really have lost their independence. And if we're thinking of them as historically meaningful markers that are independent of period effects, that doesn't seem to be the case. But what does seem to be the case is that we're looking at some very powerful period effects, which have seem to have a combined bearing on some of these important outcomes measures over many, many years. And of course, we have a period here which is being framed by the Great Recession and COVID-19. Now, this is also from our own data, but I think it tells a parallel story. Again, in our 6 companies, approximately 1,000 workers. One thing that happened in the mid-2000s to late first decade during the Great Resignation is that people didn't leave work. And this had quite a lot of effect on our studies because we wanted to look at turnover and retirement, health and turnover as major outcomes. But in fact, the 3.1 annual rate of leaving employment was historically very low. It was about 40% of the historic rate. Now, when we looked at 2011 and 2014, it was approaching the normal rate. In the 2014 to 2019 period, we actually had a growth of people leaving, which was higher than historic norms. And what we're seeing this year and the end of last year is that it's much higher. So we can look at this Great Resignation that has been called in 2 different ways. One is that with COVID-19 and maybe people taking a different view of life, and there being labor shortages, which were certainly predicted back in the 80s in terms of the aging workforce, that all of this is somehow very new. But looking at it differently, this has been a long-term trend of when people are able, when they have a little bit of whether it's social or in terms of personal resources, some leeway. Some of that discontent that we saw in our psychosocial measures seems to be carrying over into action. Now, having said this, what do people want? We can propose what people want, but here we have an active environment where we can actually query through both survey and through focus group. And what we're seeing is that what people are looking for, particularly as they're thinking of as they're aging, and the longevity of work, are several things. People do want to work from home. They want part-time work. And with that, they want flexible work hours. They want more control over what happens in the workplace. Lighter duties were not the primary consideration, although we pay a lot of attention to it in occupational medicine. We pay a lot of attention with quality of work life or quality of life to driving, commuting. Those don't seem to be big factors. There are issues around pensions, time off for medical appointments. But the main thing I think that we see is that people want much more flexibility in their workplaces, particularly as they age. And this is usually not what we conceive of as total worker health type of interventions, but it's very at the heart of what people say that they need. Now, I wanted to talk about healthy aging and work in the same workforce, and just to look at perhaps the right column. So what we can see is there actually is a lot of interest in multiple sources. There's interest in retirement bridging. There's interest in worksite health promotion. There's interest in work organization. There's interest in improving the physical work environment. In many cases, people say that they're there as provided by management. In many cases, they're either not there, people don't even know that they're there, but they're not really being utilized. And so there's something about the format that's occurring, even when companies say that they're present, which really stands as a significant barrier. So I want to just say a word, and I know I'm going to start running late, about what I'm calling fractious business. So this is important to consider, and it really gets back to a little bit about the Fischer workplace. There's something quite profound going on with American companies in terms of their organization ownership. And we talked a bit about contracting out and Fischering. But another thing to keep in mind is whether we're talking about high tech or manufacturing, traditional, large companies are getting more and more centralized. Now, what does that mean? That within every sector, there's a smaller number of companies controlling larger sectors of the economy and the workforce? Well, I'm not going to give a final answer because this is an area that we all need to be looking at, but I will point out a local answer. So we look at our companies that we had in our agent study, and we chose companies because they were very stable. You know, they made the same things for many years. They had very traditional companies. Some of them had, with their fortune listings. One of them went back to the 18th century with its stock listings. In a very brief period, 4 of our 6 companies changed ownership. One became an international. One changed ownership and was entirely reorganized. Except for one family-owned company, every company has significantly changed over a relatively brief period. Now, what did that mean? One of the things it meant is that management and HR was remote. In many cases, there was no recognizable HR department because it was maybe sitting not in Connecticut, but in Phoenix. We saw that EH&S was less of a senior administration function, but actually more of a shop and working division function. What we've seen in the last 2 to 3 years is finally this concern about maintaining skilled workers, which when no one was leaving work seemed to be off the agenda. Now it's becoming very important. And management is very remote. One of the things that's gone on at the same time is that although there's been tremendous change in the way that companies are organized, what they produce, how they're owned, we've found that the actual workforce populations over a 14-year period and have been stable, and their benefits and wages have been stable with mild decline, which is to say, not so stable. Because in fact, these are very gradual changes, generally for the worse, not dramatic, but at a time when the companies are undergoing big change. So we have to be thinking about these discrepancies if we're going to proceed with this. Now, I've given you kind of a negative picture, so I want to end up on a little more of a note of how do we go forward. I mentioned David Weil's work and some of his suggestions on the regulatory front. I think there's some things that could be said politically, which we're seeing a bit of, at least hints of, in the Biden administration with policy. But I want wanted to talk a bit about some of the work we've done, just for about 2 minutes. We've been working for a very similar period of time, about 16 years, in corrections, which is a very unlikely area for occupational health. And this is not with inmates, this is with the staff. And we got interested because of these terrible health parameters. And this is just to say that when this goes back to the early 2000s, looking at hypertension, that we saw hypertension and pre-hypertension well above the national norms in younger workers. Now, if you wait until they become in their mid-50s and 60, they look like the national norms. But by that time, they've had 30 years of this. And that, we would presume to argue, has an impact. Our response has been working with a fairly complex set of structures of worker-led design teams, which in and of itself requires not just training of workers, but significant training of management, so that they end up embedding, institutionalizing the change of kind of some forms of workplace control, particularly around what I would call total worker health interventions, looking at both individual health and changing work conditions. Now, you might say corrections is so exceptional it has no meaning to anything else. But remember, this is the period of de-incarceration, and where prisons are closing, and where the work itself, despite some reform in Connecticut, is very hard work and very stressful work. And this is just some results from one of the design teams, and this goes right into COVID-19. So we've had these particular teams which have been developing programs, some of them quite innovative, and then they follow them out and work on them. And this just takes a couple of examples. This is about overall staff awareness, which is to say awareness and then use. So what's really had big effects? Well, one of the things that the design teams wanted to do was to put in, is called report writing rooms. But the real idea is that there's these many bureaucratic functions around incidents and stressful events that are dealt with in the open with very encumbering forms that people really don't necessarily know how to fill out. They have to, many of the interpersonal exchanges, which are hostile or non-civil, end up taking this highly bureaucratic form. So that's been looked at, and that's had a rather large impact. Another area was to build decompression time and space into the work process, so that rather than kind of sitting there and sucking it up and waiting to get out, and maybe expressing it later, drugs, drinking on your family, you develop both physical space and exercises for decompressing at work, for kind of changing the flow of things. Now, you can say, well, this is corrections, but as some of you know, when there was somewhat more autonomy in workplaces in Scandinavia back about a decade ago, this was incorporated into the workday in Volvo, for example. So what have we seen? Even with COVID-19 and the negatives, when we look at decompression time, these are increasingly utilized. Suicides, assaults, these are harsh events, but we see a response to it. Does this mean that people are going to be much healthier 15 or 20 years from now? Well, we don't have 15 or 20 years to look forward to, but we do know that behavior is changing and the institutions are behaving, and we don't have to necessarily limit ourselves to a short time frame. So what can we say about defracturing workers? One of the things we've seen is that workforce will utilize total worker health and health approach interventions, but not in isolation if they're removed from the entire process of organization and conditions of work, and not if imposed from above and forced. Organizational work factors are as important as physical factors in the way people behave, the way they look at work, the way they feel they can change conditions. There's an overwhelming desire for more control and autonomy. And that was true in manufacturing, and it's true in corrections. What we saw, some areas that are just overlooked where specific measures can help. For example, we found that elder care needs were very large, 15, 16% at any given time. Of course, they change because people get better, independency, they die, they go into institutions. But at any given time, it's a significant burden. And that's where we've seen a lot of impacts of health effects. It's an area where the employer can actually become quite engaged as well as the community. If we think about organizational changes and health changes and integration as requiring participation, rather than simple programmatics that are imposed, the costs are not necessarily that great. And the last point I think I'd like to make is the quality of work-life interventions are continuous, not time limited. It's like primary care in this sense. It's a life and work-life process. We don't do it for a year and measure and then either say it costs too much money or go home. Once it's there, and workforces who are engaged and participatory understand this very well. It has to be and will be ongoing because people will maintain their interest. So I'm going to stop there.